Assalamu alaikum and good day. Today we are going to look at pathology of oral cavity, salivary gland and the esophagus. At the end of the lesson, the students will be able to list and describe the lesions in the oral cavity, neoplasms in the salivary gland, and the lesions in the esophagus. The major pathology in the oral cavity that we will look into is inflammatory or infective lesions, premalignant lesions, and malignant neoplasms. A common lesion in the oral cavity is the aphthous ulcer. It's very common in the first 2 decades of life, and it's caused by many factors. For example, emotional stress, trauma, hormonal causes, autoimmune disease such as celiac disease, inflammatory bowel disease, and Behçet's disease. It is painful and often recurrent. It usually display as a single or multiple shallow ulcers with necrotic base and hemorrhagic rim. These aphthous ulcers typically resolve spontaneously in 7 to 10 days. A common disease in Sarawak is hand, foot and mouth disease, HFMD. It is caused by intestinal virus, Coxsackie virus and enterovirus 71. HFMD can affect any age, but children 5 years and below are most susceptible. They make up around 90% of cases. The symptoms are fever for 2 to 3 days, sore throat, rashes, mouth ulcers, poor appetite, vomiting and diarrhea, and tiredness and weakness. HFMD caused by enterovirus 71 may be associated with meningitis and encephalitis. Cases of fatal encephalitis occurred during outbreaks of HFMD in Sarawak in 1997. This picture shows the rashes and the mouth ulcers that can occur in HFMD. The disease is most contagious in the first week of the illness, and the virus is transmitted from person to person from the body fluids. Another common infection in the oral cavity is herpes simplex virus, usually caused by type 1 HSV. It causes cold sores or clusters of small vesicles on the lips, just like shown in the picture. It may also cause gingivostomatitis in children, pharyngitis in adults with lymphadenopathy, anorexia, and fever. Most individuals who have been infected have latent virus in the ganglia, and it can be reactivated after a common cold, hence the name cold sore. Histologically, you may notice eosinophilic intranuclear inclusions and giant cells, as shown in the picture below. Next, we look at oral candidiasis, or sometimes called thrush. Candida albicans is a normal component of the oral flora, and this is a common fungal infection of the oral cavity. Oral candidiasis is seen in diabetic patients, patients with neutropenia and immunodeficiency. It can also be seen in bottle-fed infants and children treated with broad-spectrum antibiotics. Grossly, you can see in the picture there's superficial white inflammatory membrane over the mucosa, and this can be scraped off. Compare this with leukoplakia, which we will see in the next section. Histologically, there are fungal bodies and there's inflammatory cells with ulceration in the tissue. Leukoplakia is a lesion in the oral cavity that is defined as a white plaque or patch on the oral mucosa that cannot be removed by scraping and cannot be characterized clinically or pathologically as in any other disease. 3% of the world population has leukoplakia, and 5 to 25% of these are pre-malignant lesions. It is caused by chronic irritation, smoking, chewing of tobacco, alcohol, and human papillomavirus. 30% of leukoplakia progress to oral cancer. A similar lesion to leukoplakia is erythroplakia. Erythro means it's red in color. So it has similar risk factors as leukoplakia, but it's less common. However, this lesion has a higher risk of malignant transformation. 60% of erythroplakia progress to oral cancer. Both leukoplakia and erythroplakia shows similar lesions histologically. There are benign epithelial thickening to highly dysplastic changes that can be seen on these two lesions. Both should always be considered premalignant. And if you see these lesions, please send the patient for biopsy. There is a lesion that is called hairy leukoplakia, which is caused by EBV infection and is seen in immunocompromised patients such as HIV patients, patients on cancer therapy, and transplant patients. The lesion is usually seen on the lateral border of the tongue, just like in the picture, and it is white, confluent patches of fluffy hyperkeratotic thickening. The lesion again cannot be scraped off, and histologically there's hyperkeratosis and hyperplasia of the epithelium. Epstein-Barr virus antigen are usually found, and it is important to note that this lesion is not premalignant. 95% of cancer in the oral cavity are squamous cell carcinoma. It is seen usually in the age of 50 to 70 years old, and smoking is the most common risk factor. There is a synergistic effect between smoking and alcohol. If the patient smokes and also drinks alcohol, there is a 30-fold increase in risk for getting squamous cell carcinoma in the oral cavity. Betel nut chewing is also a risk for squamous cell carcinoma. Other risk factors include chronic irritation, radiation, sun exposure, pipe smoking, HPV infection, and lichen planus. The most common site for squamous cell carcinoma is the lower lip. It can also be seen in the floor of the mouth, the tongue, the hard palate, and the base of tongue. Grossly, it can appear as an ulcer, like this one, with raised irregular border, also like here. This is an ulcer, and it can be superimposed on the background of leukoplakia and erythroplakia, just like this lesion. Microscopically, the squamous cell carcinoma will show features typical of the squamous cells. You can see here intercellular bridges and individual keratinization, and also keratin pearls. So these are all features that are common in squamous epithelium, and this is a well-differentiated squamous cell carcinoma. Another lesion that is common in the oral cavity is basal cell carcinoma. It's the most common cancer of the upper lip. Remember, we talked about the squamous cell carcinoma affecting the lower lip. Yeah? The basal cell carcinoma is associated with ultraviolet light exposure and occurs in sun-exposed areas. Another feature of basal cell carcinoma is it invades to the surrounding tissue, but it does not metastasize. So we've looked at the pathology of the oral cavity. We've looked into the inflammatory and infective lesions, pre-malignant lesions, and malignant lesions. Now we look at the pathology of the salivary gland, and the major pathology in salivary gland are either inflammatory or neoplasm. Inflammation of the salivary gland is called sialadenitis. This may be induced by trauma, viral infection, bacterial infection, or autoimmune disease. The most common form of sialadenitis is mucocele, and the most common viral cause of sialadenitis is mumps. Non-specific bacterial sialadenitis most often is caused by either Staph aureus or Strep viridans after ductal obstruction by stones. This picture shows mucocele. This is often seen in the lower lip as a result of trauma, and this occurs at all ages. The presentation is a fluctuant swelling with blue translucent hue. This picture shows a patient with mumps affecting the parotid gland, and this is due to a viral infection. Sjogren's syndrome and autoimmune disease can also affect the salivary gland, and it causes xerostomia or dry mouth. Granulomatous infection or granulomatous diseases can also affect the salivary gland. Tuberculosis and sarcoidosis causes granuloma formation in the salivary gland. Most of the neoplasm of the salivary gland occurs in the parotid glands, and then about 10% in submandibular glands, and others are in the minor salivary glands. Examples of benign neoplasm in the salivary gland is pleomorphic adenoma, which is the most common benign tumor of the salivary gland. The example for the malignant neoplasm in salivary gland is mucoepidermoid carcinoma, which is the most common malignant tumor of the salivary gland. Pleomorphic adenoma is the most common salivary gland neoplasm, and most of it is seen in the parotid gland. Grossly, it shows an encapsulated lobulated tumor. This is a lobulated tumor, and there is a capsule, but the capsules are usually not fully developed, and the tumor can protrude into the surrounding tissue. The tumor behaves as a slow-growing tumor, which is painless, and recurrence of the tumor occurs in 4% of cases. This is due to incomplete excision. The name comes from the histological features of this tumor, which is a mix of epithelial elements and the mesenchymal elements. You can see these are the epithelial components, which is made up of ducts and acini, and the surrounding tissue here are made up of chondroid component, which is mesenchymal. Most of salivary gland tumors are benign. The risk for getting salivary gland malignancies increases as people get older. They are more common in men than in women. It is more common in patients who had radiation therapy to the head and neck. And there are cases where there is family history of salivary gland cancers that runs in the family. Now we will look at the pathology of the esophagus. We will look at congenital anomalies, motor dysfunction, varices, esophagitis, and neoplasms. We look at congenital anomalies of the esophagus. Atresia is failure of canalization of the esophagus, and fistula is where the esophagus has connection with the trachea. Both of atresia and fistula can present with polyhydramnios. Atresia because the infant cannot swallow the amniotic fluid, and fistulas because the swallowed amniotic fluid cannot be reabsorbed in the small intestine. Stenosis can be congenital or acquired. It is also associated with gastroesophageal reflux, radiation, scleroderma, or caustic injury. Webs and rings can occur along the esophagus. esophageal webs. When it occurs, usually it occurs in the upper esophagus and is associated with iron deficiency anemia, glossitis, and chelosis. There is a risk for post-cricoid esophageal carcinoma to occur in Plummer-Vinson syndrome. Achalasia is failure to relax the lower esophageal sphincter. To relax the lower esophageal sphincter, we need the inhibitory neurons to release nitric oxide and vasoactive intestinal peptide. If there is dysfunction of the inhibitory neurons, the muscles of the lower esophagus will fail to relax and achalasia will occur. Primary achalasia is rare, but secondary achalasia is associated with Chagas disease, where there is the parasite Trypanosoma cruzi destroying the ganglia. Other infiltrative diseases such as amyloidosis, sarcoidosis, and malignancies can also infiltrate and destroy the inhibitory neurons. Diabetes mellitus is also a cause of secondary achalasia when it causes neuropathy. One of the treatment for primary achalasia is nitrates. Nitrates will decrease the LES pressure. Patients with achalasia will have progressive dilatation of the esophagus above the lower esophageal sphincter. Over time, the esophagus cannot empty the swallowed food into the stomach, and this causes megaesophagus. Microscopically, there will be loss of ganglion in the mesenteric plexus of the esophagus, and clinically, this will present as progressive dysphagia. It can rupture and cause substernal pain. There is a risk for squamous cell carcinoma to occur in the esophagus. Hiatus hernia is a condition that is characterized by the separation of the diaphragm and protrusion of the stomach into the thorax. Symptoms are similar to the reflux disease, and the complications that can occur is ulceration, bleeding, strangulation, and perforation. Diverticulum or outpouching can occur in the esophagus due to the weakness of the muscle. Zancus diverticulum occurs in the pharyngeal region, and traction diverticulum occurs in the lower esophagus. Zancus diverticulum presents with painful swallowing, halitosis, food regurgitation, and inflammation of the diverticulum due to retention of food elements and secretions within the lesion's pouch. Mallory-Weiss syndrome refers to longitudinal mucosal laceration or tear at the esophagogastric junction. This is usually seen in alcoholics with excessive vomiting and bulimia. It is also associated with hiatal hernia. Grossly, you can see a linear laceration at the esophagogastric junction. Another syndrome that is associated with a tear and rupture of the esophageal wall is Bohavi syndrome. This can also occur due to excessive vomiting. Varices are veins that are enlarged or swollen. They occur at site of portosystemic anastomosis. In the esophagus, they occur at the anastomosis of left gastric vein and esophageal vein of lower end of esophagus. They are associated with portal hypertension and cirrhosis. Grossly, you can see the dilated vessels beneath the mucosa, and they tend to bleed because the mucosa and the blood vessel wall is very thin. So they have a high risk of rupture and cause hematemesis. This can cause death. Variceal hemorrhage has 15 to 20% mortality risk, and they have even higher risk for recurrence. Now we look at esophagitis. The stratified squamous mucosa of esophagus may be damaged by a variety of irritants. They may be from chemicals, infectious agents, reflux, radiation, and immune diseases. The symptoms of esophagitis range from pain, especially on swallowing, or called odynophagia, hemorrhage, stricture, or perforation. Infectious esophagitis is more common in immunosuppressed patients and AIDS patients. It causes acute inflammation and ulceration within the mucosa of the esophagus. Eventually, it can cause granulation tissue and fibrosis. The causes of infectious esophagitis includes cytomegalovirus, herpes simplex, and candidiasis. Viral infection causes intranuclear inclusions in the infected cells, just like these ones. Barrett esophagus is a metaplasia from squamous epithelium to intestinal type epithelium at the lower esophagus around the lower esophageal sphincter. It is due to prolonged exposure to the gastric juice. And the whole process is called intestinal metaplasia. And you can see there is going to be goblet cells and villi formation replacing the squamous epithelium. This is a complication of long-standing gastroesophageal reflux and the most important risk factor for esophageal adenocarcinoma. The patients tend to have long history of heartburn and massive reflux. The first picture shows normal gastroesophageal junction. You can see this is the squamous mucosa, and then this is the glandular mucosa. If you see in the second picture, this is Barrett's esophagus. So you can't see the clear junction between the squamous epithelium and the glandular epithelium. All you see is redness of the mucosa, and you can see some islands of remnants squamous epithelium. Histologically, you can see goblet cells. You can see one goblet cell here, another here, another here. And then it's being replaced by this glandular epithelium. This is supposed to be a squamous epithelium area. Only a small percentage of tumors in the esophagus are benign, and they are composed of leiomyomas, fibromas, lipomas, and hemangiomas. Malignant tumors of the esophagus composed mainly of carcinomas, mostly squamous in origin. In Malaysia, esophageal cancer has an age-standardized incidence rates of 2 per 100,000 population. In Malaysia, it's more common to see squamous cell carcinoma as compared to adenocarcinoma, but adenocarcinomas are increasing in number. The most common type of carcinoma in the esophagus is squamous cell carcinoma, mainly affecting patients above 50 years old. Males are more affected than females, and there are regional variations. There are high incidence of squamous cell carcinoma in Iran, Central China, South Africa, and South Brazil. This is a list of risk factors that can cause high incidence of squamous cell carcinoma of the esophagus. Note that alcohol and smoking causes 90% of squamous cell carcinoma in Western countries, and there are synergistic effects between the two factors. Hot served meals or beverages can cause thermal injury and thus causing esophagitis, which can be precancerous. Other conditions such as achalasia, Plummer-Vincent syndrome, esophagitis of long duration, deficiency of vitamins, deficiency of trace elements, high content of nitrites and nitrosamines, and betel nut chewing. The lesion usually starts with squamous dysplasia, progressing to squamous cell carcinoma. Grossly, we can see a fungating irregular tumor, and the most common location is in the middle third of the esophagus. Histologically, you can see the intercellular bridges and keratin pearls and individual keratinization. The most common symptom for squamous cell carcinoma of the esophagus are dysphagia and odynophagia. Patients can also present with progressive obstruction, weight loss, regurgitation, bleeding, and hoarseness. There is earlier detection of esophageal squamous cell carcinoma because of endoscopic screening, and this is very significant because if the tumor is a superficial cancer, then the 5-year survival rate is about 75%. However, overall, the 5-year survival rate is around 20% for squamous cell carcinoma of the esophagus. Another cancer of the esophagus is adenocarcinoma, which is usually seen in the background of Barrett's esophagus and long-standing reflux disease. Other risk factors include tobacco use, obesity, and radiation therapy. The risk for adenocarcinoma is reduced by eating diets rich in fruits and vegetables. Some Helicobacter pylori infection can also decrease the risk for adenocarcinoma of the esophagus by causing atrophy and reducing the acid reflux. The pathogenesis of adenocarcinoma of the esophagus follows the stepwise acquisition of genetic changes. Initially, it starts with reflux esophagitis, and then there is going to be changes in intestinal metaplasia of the lower esophagus. So as time goes by, the genetic defects and mutations are seen in the epithelial cells, and the epithelial cells becomes dysplastic. And with time, there will be more genetic damage, more injury, and the dysplastic cells develops into adenocarcinoma. Grossly, you can see this is the gastroesophageal junction. This is the normal squamous mucosa, and in between, this is the velvety red Barrett's esophagus, and you can see there's a tumor here, a fungating irregular tumor at the gastroesophageal junction. This is metaplasia area. You can see the glands with goblet cells here. So this is Barrett's esophagus, and here you can see the glands are starting to invade into the tissue. So this is the adenocarcinoma area. So you get the Barrett's esophagus and the invading glandular component, the adenocarcinoma. The clinical feature of adenocarcinoma of the esophagus are similar to the squamous cell carcinoma. The patients will present with dysphagia, weight loss, bleeding, and chest pain. And the prognosis depends on the extent of the tumor. If the tumor is limited to the mucosa, there's an 80% 5-year survival rate, almost similar to the squamous cell carcinoma. By the time the symptoms appear, the tumor usually have spread to the lymphatic vessels, so the prognosis is poor, around 25% 5-year survival rate. So we have covered the pathology of the oral cavity, the salivary glands, and the esophagus. Thank you very much.